Hello everybody, my name is Paul Rodriguez and I'm here to present my research project, Could the NHS Scare People into Healthy Habits? So the motivation of this research project is the global concern on non-communicable diseases, such as heart diseases. Currently, public policy is oriented on identifying people in risk, like for instance this advertisement in the right is some of the ones that you can find in the tube nowadays, and it's presenting some information that encourage people to check the risk to develop type 2 diabetes. So public policy is oriented in identifying these people in risk, and one of the main recommendations a physician will tell you about these possible risks is that having a healthier lifestyle will prevent or delay the onset of some of these diseases. So this yields to my research question. On what extent people modify their behavior when receiving information about their health? Let's consider that someone receives some bad news about their health. So according to the Grossman rational addiction model, this person is now facing the choice to make some investment in their health. For instance, this type of investment could be quitting smoking. However, providing information might not be useful. There is evidence showing that smokers already know the risk they are facing, so perhaps they are a selected group that are the ones who get the smallest benefit for quitting, the ones who are still smoking when they are 50 or 60. On the other hand, individuals respond to their health in terms of their behavior, as shown by Archidiaco and other papers. Moreover, there is evidence showing that smokers' health perception is sensible to diseases related to the smoking, and the smokers tend to be optimistic about their own mortality. So maybe there is some room to improve there. However, people do select into this bad news. Why? Because people select into screening procedures by visiting the therapists, that is, for assessing the risk, as we have seen in the advertisement. So if some people visit more the doctor, and that is related to the sensibility that these people might have to bad news in terms of their response, their behavioral response, then the estimates on how people react to the news could be biased if they are only based on self-report diagnosis. So for instance, if we are thinking not in diabetes but in the case of high blood pressure is a condition that people might not notice because it's asymptomatic. So if we only observe transitions on smoking, for instance, based on the transitions on self-report diagnosis of high blood pressure, this could be a bias estimator. So which are the objectives of the research project? First is to identify the potential long-run impact on behavior of policies based on health checks. Second, to determine if it is worth to target such policies according to the potential effectiveness of these recommendations. And as we will see, the main contributions of this paper in terms of literature will be the estimation of a structural model with endogenous mortality using subjective survival probabilities, that is, employing mortality beliefs that allow us to identify the model using milder assumptions on knowledge and smoking consequences and their knowledge on the mortality process itself. So this presentation is organized as it's presented here. First, the introduction that I have just told you. I will now present the model, this theoretical framework showing the relationship between smoking, high blood pressure, and mortality beliefs. Then I will describe the dataset that I'm using and its two main advantages. It's one, an advice procedure that will allow us to have a cleaner way to avoid the endogeneity produced by self-reported diagnosis and behavioral responses, and also the mortality beliefs that I was discussing in the objectives. After that, I will present an exploratory analysis, do some estimation of the model and analyzing the impact and do some simulations with it. And then I will discuss some of the next steps of this research agenda. So let's enter into this model of smoking, high blood pressure, and mortality. In this case, individuals make a really simple decision. Basically, they decide whether they are smoke or not, period by period, and they are facing a taste shock for smoking, period by period. So if they decide to smoke, they will get an utility alpha 3 against the utility alpha 1 that is obtained for not smoking. There is habit formation on this model, so you get an complementarity, an adjacent complementarity alpha 4 for smoking now and having smoking the last period, and you get a penalty alpha 2 for stopping smoking. That reflects addiction. Moreover, I'm allowing for heterogeneity in terms of the age of people, so it is allowed that people stop smoking because they don't like any more smoking with age for reasons that are not related to health. And I'm also allowing the taste of smoking to differ by gender. That is something usually observed on most of the studies. But why people stop smoking? Because there is a trade-off with future health. So smoking now affects the probability to be diagnosed with high blood pressure, and it also affects the perceived evolution of health. So let me discuss this more in detail. How people get a diagnosis of high blood pressure is a complex process. First, it depends on the choice of people of visiting the doctor, then it depends on the doctor's decision of ordering a screening test. Then it also depends on the accuracy on the test, but it also could be that you have an accident or you have a strong flu and that's why you have visited the doctor. And then they found it, say, by mistake, by casualty. So it depends on an unobserved process that I will call V1. It depends on your age, as it's a process that is ongoing with age. It depends on your previous choices on smoking. It depends on what you know about your blood pressure from previous measurements. And I will say that it depends on this external source, that it will be the advice. So when you receive an advice, it will be more likely that you get a diagnosis. Of course, some people might not develop at any time the disease or this condition. So I'm allowing for heterogeneity on the base risks to be diagnosed with high blood pressure. Notice also that high blood pressure is an absorbing state. So once you get diagnosed with high blood pressure, you will stay with it forever. And that it's a chronic disease. Now let's discuss about the health. So what I'm modeling here is that health perception is something that gives the individual some idea of when are they going to die. That is, it is affecting the mortality risk period by period. So the perception of health basically depends on people's age, so there are differences by gender, but it also depends on high blood pressure, both directly and both by enhancing the damage generated by smoking. I'm also allowing to people differ on the types of risk that they are facing percent due to genetic reasons or general behavior of the people. As we were discussing before, there could be some types of agents, but we are not really sure which are these types. But what we can do using the unobserved heterogeneity strategy is to determine the probability to belong to an observed type G, depending on some observable, for instance, our education, some information that we have related to the family of the individuals, and so on. So for summarizing this, the individuals are facing a dynamic discrete stochastic choice model. Basically, their choice, depending on not smoking or smoking this period, depends on the utility they get in this moment, and depend as well on the mortality risk from next period and on the continuation value if they are alive. So let me put it in this following diagram. Period by period, there is a realization on the shocks of mortality, high blood pressure, and the taste shocks. Then nature decides if people develop or not high blood pressure, and if people die or not. And if people die, they get an utility of value 0. That is the same utility that you will get at age 101. So I'm assuming everyone is going to die for sure at that age. And if people don't die, they will get they can now choose whether they smoke or not, and that determine the continuation value that they are assuming. So let's discuss now about the data set. So I'm employing the English Longitudinal Study of Aging, the ELSI, that is a representative sample of English population aged over 50. So it is based on the Health Survey of England, and it resembles the HRS, the Health and Retirement Study for the US. So the first important feature is that after the face-to-face interview, people is offered with a nurse appointment. So the idea is that these nurses will come 1 week after the main interview, and they will collect objective information on respondents. So for case of wave 0, that is the baseline, the Health and Survey of England, they will get a first nurse visit if they accept to do so. Then the first wave of the LC doesn't have this type of advices, but the wave 2 have again a nurse advice round. Finally, wave 4 will also include this nurse advice, this nurse visit, sorry. So why is this important? First, remember that individuals do select into screening procedures, and that is something that is problematic for the estimation of the response to health information. So the ELSI has a feature that provides a cleaner approach to it. It is not that the ELSI will diagnose a particular condition, but using information from their collected measures, they will provide an advice or not to visit a GP for a proper test. So it is encouraging people to visit their doctor, or some people to visit their doctor in order to get a proper test for hypertension, for high blood pressure. So it will give us an intention of the treatment. So the procedure works as follows. Depending on your systolic and diastolic blood pressure, you will get an advice for visiting or not the doctor. So for the case of systolic blood pressure, if your blood pressure was above 140, then the nurse will tell you at the end of this measure, your blood pressure is a little bit high today. It doesn't mean that you have a hypertension, but it's recommended that you visit your doctor in, say, 1 week, 2 to 3 weeks, 3 months, depending on how far it was from 140, in order to confirm that you have or not the disease. If you were below, the nurse just will tell you that your blood pressure is normal, and don't make any more comments than these ones. So of course what the nurses are doing is not a proper screening test of high blood pressure, but again the idea is that they are encouraging these people in the gray zone to visit the doctor, and they are not doing any explicit comment on visiting or not the doctor in the white zone. So what I'm going to do now is to compare the likelihood of being diagnosed with high blood pressure in the next wave, depending if you were above this recommendation threshold or before or below. So this equation is doing precisely that. This advice is 1 when we are in the gray zone of the previous picture, and it's 0 if you are below the threshold. I'm controlling for the blood pressure measures that are used for constructing this advice, for defining whether they advise you or not, and some additional controls. So what we find is that in column 3 is that there is an increase in around 3 percentage points on the likelihood to be diagnosed with high blood pressure if you were advised by the nurse to visit the GP. So let's take into account that number because we will compare it with the results produced by the model estimation. So the second feature that it's important are the subjective survival probabilities. In these surveys, as well as in the HRS, it is just a simple question: what are the chances that you will live to be 75 or more? And they show you this ruler that is giving you the potential responses that you can give. Of course, this type of questions have some challenges. For instance, people is not going to respond 82.5. They are going to respond you 80 or 85 or 90. Yeah. But there is a lot of work showing that this type of this information is useful. It's useful for predicting actual mortality of people, and on the aggregate behaves as good as information that could be collected from life tables. So when we try to construct the same information using the model, now we're facing how complex the question is. Let's imagine that you are age 50 and you are presented with this question. According to the model, you will take into account all the possible shocks that will occur on age 51, 52, 53, and so on, up to age 74. And you will also consider your best decisions for smoking for ages 51, 52, and so on to age 74. That is because the hazard rates for each period depends on these future shocks and future decisions. However, we can express it in a recursive way easily, so that the beliefs of surviving to age 75 from this period are the same to the belief from surviving to age 75, but for the next period times the survival probability to survive for age 50 to 51 in the example that I was given. So then the only information that it's used are my current choice of smoking and my expectation of the future shocks that will occur during age 51. And I keep using an optimal value for the subjective survival probabilities from the following periods. So in that way, whereas the likelihood of the survival probabilities is really complex, it is easy to simulate them using the model. So that will determine how we are going to do the estimation of this model. So let's move into the exploratory exercise. Basically, we are using a restricted sample and a strictly balanced panel. That means that I'm artificially selecting the sample. I'm also imposing this cohort restriction, people aged between 50 and 57 during the first wave. That is in order to make it that people in the last wave are at most 65. That is in order to make that everyone was eligible to respond the survival probability question to age 75. I also have used a simplified version of the model that doesn't allow for unobserved heterogeneity, and the sample is truncated one standard deviation above and below the threshold for systolic blood pressure, as this is this gray area that is in this graph. So the reason why is because the blood pressure evolution is not going to be modeled in this exploratory exercise is not modeled. So the advice is not a function of the blood pressure, but it's just a random assignment that occurs in each of the three waves where there was a nurse visit. So now, as I was discussing before, due to the high dimensionality of the subjective survival probability subject, the model has to be estimated using simulated methods. Moreover, as these objective survival probabilities behave as good as aggregate mortality information, it is a good idea to use the simulated method of moments, because it will allow us to take advantage and get rid a little bit of the measurement error produced by focal responses, for instance. So I'm matching 33 moments for estimating 16 parameters in this exercise. So the current graph is comparing the results of, that is a first set of moments produced by the data in red with the information that it's simulated by the model that it's using the estimated coefficients. So what we can observe there is that there are some differences. For instance, the blood pressure prevalence is still underestimated by the model simulations compared with the real data, and the slope of survival probabilities is overestimated using these estimated coefficients when comparing it with the real data. This second set of moments are here for understanding the transition. So for instance, we are comparing the prevalence of smoking conditional on having been diagnosed with high blood pressure, and in particular I want to emphasize on the prevalence of high blood pressure conditional on having been advised in the previous wave by a nurse to visit their GP. So in wave 5 we can see that there is a difference between this red diamond, that is the observed data, and the blue star, that is the simulated version. So the blue one is overestimating the observed prevalence, and the reason why is because we are not including unobserved heterogeneity. So for the current model, as it is randomly allocating people into blood pressure, where we into the advice, and then it is deciding whether they have or not high blood pressure, what we have here is that the blue stars tend to be more or less in the same impact, like 10, 12, 15. But in the real data there is more variation, and in particular in wave 5 it's a low value. If we had an unobserved heterogeneity, it could be simply that the ones that are here are those who are really hard to develop a high blood pressure at any point in their lives. That will be it would be possible to capture this phenomenon with that version of the model. So now I'm going to discuss about the impact of the model. What I mean by impact is the difference between the simulated scenario with and without the nurse advice. There are these values in red that I have this in. So what I'm doing is averaging over different simulated scenarios the difference on prevalences in those two cases. And we find in row 1 an increase of half percentage point in the likelihood to develop high blood pressure. If we get back to our reduced form analysis, this number was close to 3 percentage points. So what it means is that this model is still underestimating the value of the value that we can see on data. For terms of smoking, the impact is really small, so it's around half percentage point. No, it's around 0.05 percentage points, so it's a really small value. But when we are taking into account this exogenous variation of diagnosed high blood pressure with the variation on the prevalence of smoking due to this exogenous reason, or at least slightly more exogenous reason, then we are finding this whole estimator that is telling us that if 100 people get diagnosed with high blood pressure, at least 18 will stop smoking. That for people that it's from a group of age similar to the ones in in wave 1, that is people between 50 and 57. Whereas these people in wave 5 are people between age 57 or similar to age 65. So in that case, only 5 of them will stop smoking. So it seems that there is a really important relationship here with age that we are going to analyze in these next counterfactual scenarios. So the lines in black are showing you this impact in terms of the current timing. The line in red is showing you what would happen if we had the intervention, the nurse advised intervention, only during the first wave. So you see that the reduction in high blood pressure only occurs in this case. And then you see that the impact on smoking is quite similar to the one obtained by the current intervention. However, if we do this intervention in the between the 8 and the 10th year, we will find that though the impact on high blood pressure could be similar to the one using just the intervention in the first year, the impact on smoking is extremely low. Moreover, both the 3 exercises are similar more or less after 15 years of the initial moment of the intervention. What it means is that this intervention is making some people that were smoking, that were deciding to stop smoking at some late age, to bring forward their quitting decision and stop smoking when they are around age 50, 55. So summarizing, according to the model, there is really limited impact on the advice of high blood pressure and smoking from this nurse advice feature of the survey, but still we have that these models differ with the results differ with the ones obtained from the reduced form analysis. So that means that we still need to work in this model, building the unobserved heterogeneity and included blood pressure evolution, modeling blood pressure evolution. However, we find a notorious response of smoking with respect to high blood pressure. So this is around 18% in the first wave. But of course, this is not conclusive evidence. We have a really big standard errors. Finally, we can say that it is telling us that is the earlier the better, this type of intervention, since we are considering the case of behaviors. So people bring forward their quitting decision due to the intervention, to receiving this health information. So what are the next steps of this research? Basically to identify the survival process by using life tables, to understand a little bit what are the gains from using subjective information, then to improve the model basically by relaxing data constraint, modeling more real mortality and attrition for allowing for an unbalanced panel, incorporating the objective measure of blood pressure into the model, modeling focal responses to try to get the proper slope that we were in survival probabilities that I was discussing before, and implement other type of simulations and scenarios of policy. So, okay, that's all that I wanted to show for this presentation. Thank you very much for